So then I use this to go down, okay? Good. There's my disclosures, not much going on there. It would be nice to be able to see it on my screen here. All right, so, it's all right, don't worry about it, whatever. CTO intervention. I'll do this in 5 minutes. Increasing in popularity, but still pretty low rates at 4.8 from the National Registry. There are now about 20 to 30 centers around this country that are working hard on the hybrid, very complex CTO cases. There are three major reasons to do CTOs: symptom control, improve LV function, survival. We all know that if you have a patient with a lot of symptoms, opening up the CTO is going to help a lot. The data to indicate improved survival, improved LV function is less robust. Less clear, so the usual survival study goes something like this. If you get the CTO open, then you get a reduction in survival. If you don't, then you get an increase in survival. If you don't get it open, you get a reduction in survival. Obviously, a lot of confounders there, so that if you can't get the CTO open, it's usually a much more complex patient. So not really good data for that. The LV function improvement, same issue. If you look at a study, it's a registry, and if you open the vessel up, you get an improvement in LV function. If you don't, you don't open the vessel, then you don't get an improvement. Well, not really a randomized data, but does make a lot of sense. So those are the reasons to try to open CTOs. What about the guidelines? I'm not a big fan of guidelines. This is a perfect example of why guidelines don't really help you. It's a 2A indication, level of evidence B. So it says you can do it in appropriate patients with suitable anatomy when performed by operators with appropriate expertise. So what does that mean? Nothing, in my mind. But we did get a wire through the circumflex. If you look at the AUC, I'm also not a big fan of AUC, but here at least they're in the right direction here. You notice that you only get an A if it's appropriate, if it's a really high level of symptoms, class 3 or 4 symptoms. I think probably, any symptoms. I don't think patients have to be loaded up with a lot of medications. I think patients would rather not have symptoms and not have to take a lot of meds. So I think we could adjust this somewhat. But one of the pleas I make to CTO operators is please don't do these procedures on asymptomatic patients. It's a stable lesion. This is not ACS generally. You really should only work on these patients if you can help them with their symptoms. The hybrid strategy is well known to those of us who do it. If you don't do this, you're going to find this very confusing. If you do this, you're still going to find it confusing. There's a lot of ins and outs with this, but if you're going to be a CTO operator, you need to spend some dedicated time and learn these techniques, and it's not easy. There's even, as Columbia, we have a whole year of fellowship in this hybrid CTO algorithm. Obviously, I can't go into the details in 5 minutes. What are the data? Well, we have the Progress CTO registry. These are really high-end CTO operators, and in some ways, this is great data. In some ways, it's not. The success rate of 89%, wow, that looks terrific. But it's still not as good as bypass surgery, still not as good as non-CTO PCI, but it's a lot better than it was. But there are complications. Here, 2.7% major complications. And if you look at the retrograde cases, and I'm sure we'll see some during this conference, the complication rate is significantly higher than the antegrade only cases. So you can take on these tough cases, but you better be prepared to deal with complications, and you better spend a lot of time learning how to do this. The open CTO is another important registry, and look at the perforation rate here, 6%. Look at the rehospitalization within 30 days, 15%. Again, we can help a lot of patients by doing CTOs, but be careful out there. You will have complications, you have to be prepared for them. This is the open CTO data. Again, another 89% success rate. Look at the time involved, 120 minutes on average, 2 hours. It's a lot longer than the usual PCI case. The long-term outcomes. What do we know about long-term outcomes? What kind of data do we have? We don't have much. All we have is the expert CTO data. The expert CTO is, though, not really applicable. It's what got the Zion stent approved for CTOs, but the clinically driven TLR rate was only 6%. That seems pretty good, but only 85% of the patients had antegrade only procedures in this. So it's really not the retrograde and the subintimal approaches that were studied in this expert CTO. The other data we have from the STAR techniques, some of these subintimal techniques are not as good. This is probably the worst, the STAR, particularly if you don't get good two-vessel outflow with TIMI-3 flow at the end of the case. And you'll see re-occlusion rates of 60% in this particular study. In some of Antonio's data, it's 30 or 40%. So we can do this, still not clearly perfected. It's going to require a lot of commitment of time and energy. I advise you to get training. There's plenty of courses available and lots of proctoring, a lot of resources for you. You need to have dedicated CTO cath lab times. For me, it's very hard. I have to dedicate one whole morning out of the week to this kind of a case, and I can only do one case. I usually like to do 2 cases, one in each room, and I take phone calls. Can't do it if you're doing one of these cases. You really got to focus on this and make a commitment. It will not cost your hospital a lot of money. That's okay. You don't have to buy a lot of equipment. They can afford it, and the hospital gets reimbursed better for CTO. I guess I'm done. Is that right? No, I'm sorry. I'm sorry. My screen changes haphazardly over here. But if you're on a fee-for-service plan, I would think really twice about doing complex CTO. So those of you who get paid by the widget RVUs, it's not a good way to make money, because you're going to spend hours and hours and be exhausted, and you get paid about 30% more to do a CTO case. For those of you who read the CCI, I thought Dr. Blankenship did a great job with this editorial last month, discussing the pressures, the sort of post-traumatic stress syndrome that we get when we're working on these very difficult cases. And if you're going to do complex CTOs, it's the old days. In fact, it reminds me of the old days. This is my mentor, Dr. Hartzler, who used to talk about stress all the time. If you're pushing the envelope, you're doing things like epicardial collaterals or even just septal collaterals, you're going to have complications, and it's going to really mean a lot to your life. That, by the way, was my graduation ceremony. He's giving me a lead-lined cup as my graduation present. So I think this is important. And so I'll put this in your mind. Some of you will like this movie, A Few Good Men. Remember when Demi Moore is advising Tom Cruise to back off of Jack Nicholson if he's not going to save, he's not going to admit it in court. And she says, if you feel like it's not going to happen, so apply this to CTO. You're doing a CTO, a tough CTO. If it doesn't look like you're going to get it, okay, don't go for it. You can get a lot of trouble. All right, so think about this scene. And I've seen physicians go on and on to try to open these occlusions, and meanwhile the patient's getting irradiated, and they're getting complications and perforation. They don't stop until they get a perforation. These are elective patients. They're walking off the street, and some of them are young, and you really don't want to get them in trouble. And my final word, I can't get up in front of a bunch of doctors without talking about our political movement here. This is before the electronic medical record, and we're where we are with the national board. We have 4,000 diplomats. It's working well. We've gotten lots of good feedback. I think the American board is doing a great job. And I just want to point out that the ABIM now has 200,000 diplomats. They have, as you know, in a couple of years, the recertification exam is going to be over. That's great. But they still want their $200 to $300 a year. That's $50 million a year. This is a toll booth that we have to stop. And I think we are. And I just got an email this morning that this week the AMA actually voted to recommend discontinuing all recertification exams at their big meeting. So I think we're on the right track. Thank you for your attention.